Yes, I'm Michael Gieske. I'm a family medicine physician, been in practice for 28 years now, and I'm here at the World Conference on Lung Cancer 2024. I've been in practice for 28 years as a family medicine physician, and during that time, of course, I've seen a lot of lung cancer. I've seen a lot of patients affected by lung cancer, a lot of families just really devastated by lung cancer and their family members. And historically, lung cancer has been a very deadly cancer. It moves quickly through the stages. It tends to be very aggressive. And unfortunately, it's oftentimes not found until the late stages. 50% of the time or more, lung cancer is found in stage 4. And I was doing some administrative work back in 2016. And as an extension of that, I was asked to be the primary care representative on the thoracic oncology disease management team. And I walked into this room full of oncologists and radiologists and very specialized physicians, and they were throwing around a lot of acronyms. I had no idea what they were talking about. SBRT and VATS and RATS procedures, and they were talking about low-dose CT lung cancer screens, and I'd never heard of a low-dose CT lung cancer screen. Low-dose CT lung cancer screens have been around for many years. They were put on the map following a landmark trial that was published in New England Journal of Medicine in August of 2011 that proved definitively that low-dose CT lung cancer screening can reduce mortality for lung cancer. And so for the first time in my career, I'm sitting here in this room full of all these geniuses, and I'm thinking, well, now we have something that can make a difference with our patients that are at risk for lung cancer, and we can catch it early. And at the time, we were doing about 200 screens a year, and I'm thinking, gosh, we've got to have thousands of patients in our healthcare system that qualify for lung cancer screening. We should be doing better than that. And so I helped to bring this essentially process or modality to the primary care providers. And I went on a road show with Royce Calhoun, who was our chief thoracic surgeon, and we visited all the primary care sites throughout our network, talked to them about low-dose CT lung cancer screening and the benefits of it and how easy it was. And as our program grew, we started getting some really good homegrown data. And it's one thing to talk about the National Lung Screening Trial, the Nelson Trial. These are both landmark studies that put lung cancer screening on the map. But when you can start to get your own results, and I can get in front of people and providers, associates, managers, executives, and I can say, we're finding one lung cancer for every 26 unique patients that we screen. We're finding 75% of the lung cancers we find now in stage 1. We're finding almost 80% in the early stages, stage 1 and stage 2. We've done over 45,000 lung cancer screens now since we started our program. And we just found our 440th stage 1 lung cancer. So, these are clearly lives saved, and where historically, most of these patients with lung cancer didn't survive more than 6 to 12 months. And we're curing these folks. We're going after it, we're catching early, and we're making a big difference. If you can catch it in stage 1, you can do a simple surgical procedure with robotics and remove that cancer, or you can do SBRT, which is a form of radiation treatment, very highly sophisticated, very focused radiation treatment. You can cure folks in stage 1 lung cancer. And the other component of that is that even when you find lung cancer in the late stages, stage 3 or stage 4, the technology for treatment for lung cancer has changed so dramatically over the last several years. We now have patients that are 15, 20 years out with no evidence of disease that had stage 3 and stage 4 lung cancer. So we think we've cured a lot of these folks. We're a little afraid to use that word still. But I think because of the success we've had in our program and the notoriety that we've achieved through our work at St. Elizabeth Healthcare in Northern Kentucky and Southeast Indiana, I became involved with the ACCC, which is the Association of Cancer Care Centers. And they were tasked with looking at Appalachia, which is a part of the country. It entails a lot of the Appalachian Mountains, and it's parts of 13 states. It's all of West Virginia. It's a big swath of land. So we were tasked with looking at this area and devising a project that we could demonstrate that we increased lung cancer screenings, and we had some significant and substantial results through that process. And so we looked at geospatial mapping for the country, and we looked at the area where it was the worst incidence of lung cancer, the worst mortality from lung cancer, and the poorest access in the country for healthcare or for lung cancer, for example. And sure as heck, it all came together where Kentucky, West Virginia, and Virginia touch. So we looked at that tri-state area. We picked a 10-county area that involved that intersection. One county in Kentucky, Pike County, working with Pikeville Medical Center, 4 counties in West Virginia, and then 5 counties in Virginia. And in Virginia, we're working with Buchanan General Hospital, who has a working relationship with the University of Virginia. And we've been helping them to refine their processes for looking at lung cancer screening and trying to develop some very good benchmarking so we can get some data points where we know where we started, and then we can figure out, did we cause some improvement? Were we able to demonstrate success through our efforts? And it's been very challenging. It's always challenging to implement lung cancer screening, for a new healthcare system or somebody that's just getting into it. But there were some unique challenges in Appalachia because of the access issues and some of the cultural issues there too. It's a difficult area to go into as an outsider and gain trust. And that was one of our chief goals, was how can we go in here, partner with these individuals in these healthcare systems, gain their trust, and collaborate to improve lung cancer screening. Well, you have to learn about the culture of the area. For example, in Appalachia, one of the things we found out was that there is a very high premium placed on family values and family input and family influence. So one of our approaches was to work with family members to gain that trust. And if you have a family member that is going to encourage you to get lung cancer screenings, they've learned about the value of it, it's so much easier to get that individual in for a lung cancer screen. And so that was one of the avenues that we used. I think reaching the primary care providers is paramount, is just critical. And if you could find primary care providers that are willing to be a champion for lung cancer screening, or that are willing to carry the torch, so to speak, and to talk with other primary care providers and create some enthusiasm, that carries a lot of weight. One of the things that I did is when we had several meetings with them, virtual and some in person, but we were able to identify the primary care providers in that region. And I went back in June and visited Pikeville, and I visited all 4 of their primary care groups and met with them on an individual, personal basis, talked about lung cancer screening, some of the results that we've had at St. Elizabeth, and then through that kind of bond, so to speak, that we created, I think it's going to improve their lung cancer screening. I just went and a couple weeks ago actually and spoke in front of their medical staff, and which was a group of oncologists, primary care providers, and other specialists, and talked about lung cancer screening and the experience that we've had at St. Elizabeth and some of the tools that we've used to increase lung cancer screening. And positive reinforcement is so key as well. If you can emphasize the positive and good results that you've had, if you can recognize those providers that have done a good job of doing lung cancer screening. For example, if I have a provider in my healthcare system that finds a stage 1 lung cancer, I send them a staff message. I say, strong work, you saved this person's life. This is, I thank you for supporting our program. These are the results that we had last year. And every year I update it. So, they know the results that are continuing to improve year after year, because this is a test that's done on an annual basis until you're either 80 years of age out of the program, or if it's been 15 years since you quit. And when you bring these patients back year after year after year, you're going to be much less likely to find a cancer in the late stage 3 or stage 4. You're going to catch it early. when you can make the greatest difference. And it's getting those kind of messages out there. Getting the messages out there that lung cancer is no longer the death sentence that we've been used to seeing it as. That it's okay, to have lung cancer. It's okay to smoke to some degree because it's a very addictive habit, and there's a lot of blame and a lot of shame that goes around with people that smoke and get lung cancer. So it's trying to work with that stigma and trying to defeat that, and helping patients to get off of cigarettes and to stop some of the bad habits that they've picked up over the years. Yeah, it's been great to be associated with this organization, and it's recognized by the President's Moonshot initiative and also the President's Cancer Panel. So it's going to get some national high level attention in this work that we're doing. And then I think we've gotten to a point where we've established a significant level of success at this point, and the individuals that are funding our program are going to continue the funding. And so we're going to be looking at doing this for another 2 or 3 years in this area, but then also branching out and going into other areas as well, and using some other tools and billboards and brochures and pamphlets and flyers and a lot of things that are going to help to improve our efforts as well.